If you're listening to this podcast on YouTube, for a better experience, switch to the video version. The link is in the top right corner of the video and in the episode description. Hello and welcome. I'm Fernando, a GP in the UK. Today we will go through the new NICE guideline on acute asthma, NG244, focusing on what is relevant in primary care only. Just like the NICE guideline on the management of chronic asthma, the NICE guideline on acute asthma is also a collaborative initiative developed by NICE, the British Thoracic Society, and the Scottish Intercollegiate Guidelines Network, or SIGN. It replaces previous guidance, and you can find a link to it in the episode description. In today's episode, I will just focus on initial assessment in adults. In the next 4 episodes, I will cover the assessment of children, treatment in adults and children, and lessons from asthma deaths and the concept of difficult asthma. So stay tuned for those. Right, let's jump into it. When conducting the initial assessment of a patient with acute asthma, it helps to follow a systematic approach because using a structured recording process helps ensure consistency in order to determine whether the patient is indeed having an acute attack, the severity of the episode, and the appropriate treatment required. So let's have a look at the different aspects of this clinical assessment, and let's start with the clinical features. Examination findings that can indicate severe asthma are severe breathlessness, including being too short of breath to complete full sentences, tachypnea with a high respiratory rate, tachycardia, a silent chest indicating minimal air entry, cyanosis, the use of accessory muscles when breathing, or signs of altered consciousness or collapse. However, we should note that while these signs are concerning, their absence does not exclude a severe attack. We should also note that although pulsus paradoxus is sometimes observed in severe asthma, it is not a reliable indicator of severity and should not be used in clinical decision-making. Pulsus paradoxus is an exaggerated drop in systolic blood pressure during inspiration, and in asthma, it occurs due to increased intrathoracic pressure. But as we have said, its absence does not rule out a severe attack. Let's now look at some measurements, starting with peak flow and FEV1 measurements. Both are valid indicators to assess the degree of airway obstruction, but peak flow is more practical in acute settings. For clinical accuracy, we should express peak flow as a percentage of the patient's previous best value when known. But if the best value is unavailable, we will use the predicted peak flow value as a rough guide, keeping in mind that different peak flow meters may give slightly different readings, so ideally we should use the same or a similar device for consistency. Let's now look at assessing oxygen levels using pulse oximetry. The target of oxygen therapy is to maintain oxygen saturation between 94 and 98%. If oxygen saturation drops below 92%, regardless of whether the patient is on air or oxygen, an arterial blood gas measurement will be needed to evaluate for hypoxia and hypercapnia, which can indicate impending respiratory failure. So, in summary, if the oxygen saturation is below 92%, the patient should be referred to the emergency department. Looking at other investigations, a chest X-ray is not routinely required for asthma attacks. However, it may be necessary in cases where we suspect pneumothorax or consolidation, or in situations when there is life-threatening asthma, failure to respond to treatment, or a need for assisted ventilation. Now, when assessing a patient with suspected acute asthma, we need to recognize the signs and determine the severity of the attack. We classify acute asthma into different levels of severity, ranging from mild to life-threatening, based on symptoms and objective measures like peak flow readings. As we said earlier, if we don't have the patient's recent best peak flow reading, that is, within the past 2 years, then we will use the predicted peak flow value as a reference. Let's now look at the levels of severity of acute asthma attacks in adults. And we will start with moderate acute asthma. Patients in this category experience increasing symptoms, but the peak flow remains between 50 and 75% of the best or predicted value. Importantly, there are no signs of severe asthma. The next category is acute severe asthma, and patients meet the criteria for this category if they exhibit any one of the following signs: a peak flow reading between 33 and 50% of the best or predicted value, a respiratory rate of 25 breaths per minute or higher, a heart rate of 110 beats per minute or more, or they're unable to complete full sentences in one breath. After this, we come to the category of life-threatening asthma, which is basically patients who already have severe asthma, who also present with any one of the following features: an altered level of consciousness, peak flow reading below 30% of best or predicted, signs of exhaustion, oxygen saturation dropping below 92%, the development of arrhythmia, hypotension, cyanosis, a silent chest indicating minimal air entry, or poor respiratory effort, which can suggest impending respiratory failure. And finally, the last category is near-fatal asthma, which is the most critical stage. It's characterized by raised arterial CO2 levels, indicating respiratory failure, and often requires mechanical ventilation. Given that we do not have direct access to blood gases in primary care, this category will only be accurately diagnosed in secondary care. Let's now look at the criteria for hospital admission. And obviously, any patient showing any feature of a life-threatening or near-fatal asthma attack should be admitted urgently. However, other factors may also warrant admission to hospital, including patients with severe asthma that does not fully resolve after initial treatment. Additionally, even if symptoms improve and peak flow increases to over 75% of best or predicted, hospital admission may still be appropriate if there are ongoing concerns. So we should also consider admission if there are persistent symptoms, concerns about medication adherence, psychological issues, other comorbidities that could complicate the management, if there is a physical or learning disability, a previous history of near-fatal asthma, an attack despite taking an adequate dose of oral corticosteroids prior to arrival, a presentation at night when follow-up may be limited, if the patient lives alone or is socially isolated, or if the patient is pregnant. And just before we finish, let's just say that, in terms of prevention, the identification of these patients who are at higher risk of asthma-related deaths is very important. Therefore, in primary care, we should maintain a register of these patients, ensuring that if they miss a follow-up appointment, they are proactively contacted. This helps prevent deterioration and reduces the risk of fatal outcomes. And equally, patients with asthma, especially those with severe asthma, should have a written personal asthma action plan which outlines how to manage their condition day to day, when to adjust medication, and when to seek medical help. Studies have shown that personal asthma action plans can significantly reduce both hospital admissions and asthma-related deaths. So that is it, a review of the initial assessment of acute asthma in adults. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guideline. You must always use your clinical judgment. Thank you for listening, and goodbye.